Welcome to today's webinar. My name is Blake Baucom and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There is a Q&A button on the right-hand side of your screen where you can type questions at any time and we'll try to get them answered during the webinar. Let me introduce Dr. Rotenberg. Dr. Sean Rotenberg received his dental degree from the Medical College of Georgia and achieved his certificate in periodontics and a Master of Science degree from Ohio State University, where he served as the chief resident. Dr. Rotenberg is an assistant professor for the Division of Periodontology at the Ohio State University College of Dentistry in Columbus. He also maintains a private practice in the Columbus area that focuses on periodontal therapy, implant therapy, and periodontoplastic surgery. Dr. Rotenberg serves as a staff periodontist for Nationwide Children's Hospital. He is a diplomat of the American Board of Periodontology and has co-authored and authored several peer-reviewed articles in journals such as the Journal of Periodontology and the International Journal of Oral and Maxillofacial Implants. Dr. Rotenberg's current research interests include soft tissue augmentation and peri-implant disease, and he has presented at both national and international professional meetings. Dr. Rotenberg, thank you so much for your time. Looking forward to hearing from you.
Thanks, Blake. Welcome, everybody, to a Wednesday evening. It's 8 o'clock Eastern time here in Columbus. So everyone, I'm sure, has been through a long, busy day, and it's hump day where we made it through. So what else would we want to do but learn about socket preservation, right? Today, I have lots of photos. It's all going to be photos, no words, lots of photos. I'm going to tell stories. It's going to be amazing. Hopefully you have some popcorn, ice cream, glass of scotch. It's just, today's going to be, I want everyone to sit back, relax, just enjoy the presentation. I'm a periodontist. I'm in a little bit of an interesting situation. My partner's an oral surgeon, so we work in a combination oral surgery perio office. We take a lot of teeth out, and the perio gods would be very upset at me, but we do a lot of implants, a lot of soft tissue. I'm lucky to have a new associate who's also a periodontist. I teach at Ohio State, and I also teach at Nationwide Children's Hospital. My original presentation was always minimally invasive socket reconstruction, and I would show these techniques on how to conservatively extract teeth and reconstruct the area so that implant placement would be successful, not just from a functional standpoint, but from an aesthetic standpoint too. But what I found as time went on were these techniques were so predictable that I could use them in even larger defects. So the topic has now kind of changed into minimally invasive socket reconstruction of severe bony defects. And my motto when I teach to residents is always, don't destroy what you can't replace. A lot of the osteogenics and bone grafting lectures that you'll hear, you'll see people doing vertical ridge augmentation, these massive, guided bone regeneration procedures. But what are we really doing? We're trying to make up for damage that's been done, either because of traumatic extraction technique or teeth that have been missing for a long time. On my end, I'm starting at the beginning. I don't want to ever have to get to that point. I don't want to ever have to get to the point where I have to vertically augment a site. And honestly, in my practice, that is few and far between. What am I doing day in, day out? I'm taking teeth out conservatively. I'm socket preserving sites, getting them ready for implants. These are techniques I use multiple times a day. And I'm sure everyone out there who's listening does the same thing too. So today's a philosophic lecture as much as it is a clinical lecture. So again, mottos: don't destroy what you can't replace. So what are we striving for? What are we striving for when we are regenerating the anterior aesthetic zone? Well, this is it. This is as a periodontist, this is the most beautiful photo I've ever seen in my life when it comes to periodontium. We have beautiful teeth, beautiful papilla, beautiful keratinized tissue, stippling, no inflammation. So at the end of the day, when I'm trying to rebuild an anterior site, this is what I'm striving for. This is the Sistine Chapel of perio, of dentistry. And we have to treat it as such. We have to be artists. As a periodontist, I'm a plastic surgeon of the oral cavity. I'm a plastic surgeon of the periodontium. What does that mean? Well, there's many plastic surgeons out there. On the right is Liam Neeson. He's glorious. Look at this man. This guy's in his like 70s. He's still saving his daughter from Russian terrorists. On the other side is Mickey Rourke, another great actor, the same age, but obviously they went to two different plastic surgeons. Did they get some sort of result? They did, but I want to be Liam Neeson's plastic surgeon. I don't want to be Mickey Rourke's plastic surgeon. So my goal today is I want to teach you, how to be Liam Neeson's plastic surgeon. I want to show you how to achieve the most aesthetic results when it comes to anterior socket reconstruction. What does that mean? That means when this lady on the right comes in, and this is a ER doctor who is 30 years old, came to my practice, and she came in with failing upper left lateral incisor. On top of that, this has been going on for about 5 years. And she says, listen, I'm so busy. I'm always in the ER. I'm always working. And what happens is I get some swelling. It swells up. I pop it. And then, what happens? It goes back down and I'm fine. And then I take a radiograph and this is what we have. So now we have to extract the lateral incisor, somehow reconstruct it. And she says, oh yeah, by the way, I'm getting married in 2 months. So what do? This is not an out of the ordinary patient that comes into my practice. Of course, everyone waits 5-10 years, but when they come in to see you, they want things right now. So what's our goal here? My goal is not necessarily an implant for this lady. My goal is I have to make her look perfect. It doesn't matter how I achieve that goal, but I have to make her look perfect. She's a young, attractive lady who's about to get married. We take a cone beam CT, and this is the extent of the defect that we see. When I took this, I was sweating. So what do? When we see a case like this, do I go back to residency? Do I go back to how I would normally do guided bone regeneration? This is a case done by one of the residents at Ohio State, and a beautiful case. Here we have number 9 and number 10, the central incisor and lateral incisor. They're failing. So what does the resident do? As we're told, let's take the tooth out atraumatically. And now we have these large bony defects. So what do we have to do? We have to regenerate them. So let's flap the area. Let's do, periosteal releases. Let's make sure we can coronally advance the tissue really well. Let's use a membrane, whatever bone material of your choice. And let's ensure that we get primary closure, because for guided bone regeneration, we need primary closure. We've been taught that. What happens when we get primary closure in the aesthetic zone, especially? We have 2-3 weeks of healing. What happened to the mucogingival junction? What happened to the keratinized tissue? Well, because we coronally advanced everything, we just changed the position of our mucogingival junction. We got rid of keratinized tissue that we could have used. Yes, are we going to have bone? We will. But we're going to spend multiple surgeries trying to recreate the damage that we've caused by doing this GBR, by doing this guided bone regeneration. On top of that, the patient's going to need provisional restorations to reshape papilla, and it's going to take a year before we finally get a nice result. So when I talk about coronal positioning, this is one of my cases. This is a case where we did a block graft, and the block graft went great. We had terrific bone. But look where my mucogingival junction is. Where did all my keratinized tissue go? To get enough coronal positioning to cover that graft and keep it covered, I completely eradicated my zone of keratinized tissue. In soft tissue augmentation, we can do the same thing as well. Here's a lady who came in who had lateral incisors with recession. So I told her, I said, hey, you know what? Why don't we, she wasn't thrilled about using her own tissue. I said, well, what if you use your own tissue for one side and we just do some coronal advancement for the other side? And that's what we did. And this is an example of what coronal advancement does in comparison to when you don't coronally advance. And in this case, on the left side, we just used an exposed subepithelial connective tissue graft. Surgically, both went well, no problems, and we got beautiful results. But if you look closely at the side that got the coronal positioning versus the side that got the connective tissue graft, what you see is that there was a change in the mucogingival junction position. There was a change in how much keratinized tissue was created on the side where the subepithelial connective tissue graft was done. So coronal advancement, as much as it's beat into our heads where you need to have good primary closure, let me show you how to release a flap. It does affect our aesthetic outcome. So back again, what do we do for this lady? I don't want to change where her mucogingival junction is. I don't want to lose the papilla, but I have a massive defect to deal with. So first thing we know, let's take the tooth out atraumatically. Okay, we know that. Keep the papilla completely intact, no flap. So as a periodontist, there's all this literature that's come out with soft tissue augmentation, and we're trying to keep things more conservative and more conservative. We've gone from pouches to tunnels to now vista and pinhole techniques. We know we can do a lot of things through the vestibule. We know we could do a lot of things by pouching and tunneling. So why can't we use that for socket reconstruction? Here, we used a vestibular approach to access the defect. I was able to very easily degranulate the defect, and you could actually see the perforation going to the palate through the access that I created. So once everything's degranulated, I placed, in this case, a collagen membrane to occlude the defect on the palate, used my bone graft material of choice to fill the defect, including the socket, placed another membrane on the buccal aspect, around the buccal aspect of the defect, and sutured. And there we are suturing. And the young lady got a provisional cantilevered crown on the canine. We waited for her to heal. And this is what she looked like after about 6 weeks of healing. Look at the papilla. Look at the keratinized tissue. Look at the mucogingival junction. And on the right, that's her finally restored for her wedding pictures. So we didn't end up placing an implant on this patient because first off, her time limitations really kind of threw a wrench into things. But also with the size of that defect, I did not feel comfortable that we'd be able to give her as an aesthetic result as this with an implant. But she still wanted to revisit it. So she came back to see me and she said, let's take a cone beam. Let's see how the bone looks. And this is how she looks. This is about a year down the line. So do I want to keep going and try to, take off that crown and do an implant? No, I don't. But eventually, if something does happen to that cantilevered crown, we do have bone for an implant at the lateral incisor site. So let's keep going. So now let's talk about, again, bigger defects. Here's a gentleman with a failed number 9 upper left central incisor, and completely failed. Large bony defect. On top of that, we have a very prominent frenum. We have the papilla on either side. If I start trying to do any sort of big flap, that frenum is going to take things. We're going to lose soft tissue height. Really challenging case. So again, first thing we know is let's take out the tooth atraumatically. And one way that I take out teeth atraumatically, I don't know what your techniques are. I like to section single rooted teeth. Anything I can do to prevent having to raise a flap, prevent having to elevate any sort of papilla. So we've taken out the tooth atraumatically, and again, now we have other literature, the use of different membranes, in this case, using the dense polytetrafluorourethane, the deep PTFE membranes, to conservatively preserve sockets. I'm thinking about using that technique in a situation like this. Now, why do I feel comfortable? Well, I use DPTFE membranes for my GBR, for my ridge augmentation. Here's a case where we regenerated the bone of a very atrophic mandible for the incisor site. Again, using very simple techniques, coronal advancement, DPTFE membrane, we're able to get Very, very predictable bone. And not only predictable bone dimensions, but the quality of bone as well. Really, when using these types of membranes, when you re-enter the site, you don't see any residual particulate. This is dense bone. On top of that, for the simple extraction cases, using the DPTFE, the TXT200 technique, it's very predictable. Here's a case where we have a central incisor that needs to be extracted. The tooth is atraumatically extracted. We were able to very conservatively pouch a space around the buccal of the defect, tuck our membrane in, place our bone graft, not elevate any sort of papilla. And the soft tissue responds very well to this membrane. And this is what things look like when we take out the membrane. So again, we're able to conserve the anatomy, especially in the anterior aesthetic zone, and get a predictable response from a bone dimension standpoint. So let's use that technique for a larger defect where people may have in the past thought to do a larger flap. So again, here tooth is taken out atraumatically. We place the dense PTFE membrane, the single. And this is how the tissue responds at the time of membrane removal, which is 3 weeks. So again, look how the tissue responds. It's pink, it's healthy. We don't see inflammation. The papilla have not changed. By the way, this patient also did not have a flipper. Flippers and Essex devices, whatever your philosophy is, as long as you don't touch those papilla, they won't change. If you elevate the papilla, yes, you do have to have something that's going to help reshape them. But if you don't get rid of the papilla, they're going to stay in place. This is what we look at, what things look like right before implant placement. And this is what the bone looks like. And again, this is bone. This is good bone. We have great dimensions. We have good quality of bone. And here we're waiting about 4 months or so to re-enter and place our implant. So implants placed very conservatively. In this case, we were only waiting 6 weeks before impressions for restoration, and the patient gets restored. We didn't lose papilla. I'm not super happy with the restoration shade, but really, if this was flapped initially, we would have had a heck of a time trying to recreate the soft tissue. And this would have been, if we had flapped this site to begin with, we're looking at having to do soft tissue augmentation at the time of implant placement, maybe additional bone grafting. But in this case, it was one surgery to prepare the site for the implant, and then the implant surgery, and that was it. So again, as far as predictability goes, even in these large defects where you would think we have to flap this, you don't necessarily need to. These are the results that you can achieve just by using the technique by pouching in the DPTFE single membrane, and it's good quality bone. This is bone that is dense. You have to use a torque wrench to get your implant into, and again, we're able to preserve our soft tissue anatomy. It's repeatable. This is another resident. This is our chief resident from Ohio State who just graduated, who went back to Cyprus. It's 3:00 in the morning in Cyprus right now. I think she's watching this, but this is her case. Dr. Theodorou, this was a great case. So she used the same technique, atraumatically extracted the lateral incisor. Look at the cone beam. We have 0 buccal plate. We have a parulus on the buccal. Atraumatically extracting it, doesn't touch the papilla, is able to very conservatively tuck a membrane, placed, in this case, just freeze-dried bone allograft, FDBA. That's typically what I use. I don't mix it with anything. I don't mix it with growth factors, PRF. We're going straight FDBA and a DPTFE membrane. She tucked it on the buccal, used some stabilizing sutures. And this is what we looked like at the time right before implant placement. Again, look where the interproximal tissue height is. Look at the keratinized tissue. There's been no change in the mucogingival junction. We could not have achieved this result with one surgery if there was a flap involved in this procedure. This would have been multiple procedures. This would have been flap and bone graft, and then soft tissue augmentation, And then on top of that, at the time of implant placement, we would have had to do a provisional to try to shape those papilla. But in this case, we haven't lost the papilla. There's not much shaping that we need. All we need is a healing abutment, and we're going to shape the papilla just fine. You know, I'm conservative. I'm simple. I like these techniques. And this is the type of bone that we're able to achieve. So what are the benefits of using the high-density PTFE membranes? Well, number one, I've shown you aesthetics. We don't lose keratinized gingiva. We don't change the position of the mucogingival junction. And we're able to keep the papilla intact. That's key. It's less resistant to infection. A lot of my colleagues I talk to who are very hesitant to use the PTFE membranes were burned back in the day with the expanded polytetrafluoroethane urethane membranes, the ePTFEs. Yes, if you left an ePTFE membrane exposed, it got infected 100% of the time. These do not get infected. On top of that, even in GBR cases, large ridge augmentation cases, even if the membrane gets exposed 8 weeks, 12 weeks out, the chance of infection and complete bone loss or complete graft loss is very, very low. On top of that, less patient morbidity. These patients come back with very, very little pain, and even to remove these membranes is just as much discomfort as removing sutures. It's very, very little discomfort. So let's go big. You know, I told you, severe bony defects, you know, where in the past people would think to flap things. Here we have a hard tissue and soft tissue fenestration at the apex of this lateral incisor. Again, young lady, very concerned about aesthetics. I don't want to lose the papilla. So there's the defect. This is what it looks like on the CBCT. So, you know, 99% of people would say, oh, we need to take this tooth out, flap it, big ridge augmentation. Look how thin that ridge is. Well, the ridge was able to support a tooth. Let's see what we can do so it can support an implant and do it conservatively. So what do? We extract the toothache conservatively. We pouch. Here I'm using a Pete Charles periosteal elevator to pouch around the defect to be able to contain my membrane. My typical armamentarium is an Orban knife, a Pete Charles periosteal elevator, and a Boozer periosteal elevator. That's it. That's all. That's what I use for everything. For these types of defects, for my soft tissue augmentation. Very, very simple. We pouch the defect. You can see the Pete Charles through the fenestration. Tuck my membrane in, place my bone graft, some sutures to help stabilize everything. This is at removal of the membrane. And this is at a CBCT that we took 3 months later. Again, for these larger defects, I'm waiting about 6 to 8 months. But this is what we look like. And, you know, at this point, I'm thinking, you know, do I need to do more ridge augmentation? Or can I use, you know, a tapered, you know, 3.3 millimeter diameter implant, which I can. So I'm able to place the implant, you know, again, good quality bone. And this is what we look like restored. 2 surgeries. Extraction socket preservation, implant placement. No additional soft tissue augmentation, no additional hard tissue augmentation. Look at the papilla, look at the keratinized tissue. Again, I feel I could not get results like this doing it any other way in my hands. Bigger defect, bigger fenestration. It worked on the last case. Let's try it on this one. This is a gentleman who has a central incisor that's resorbing. You can see the fenestration. Previous history of endo. So what do? I don't want to lose papilla. We're going to use the exact same technique. Atraumatic extraction. Whatever you have to do to take out this tooth atraumatically, do it. Papilla completely intact. Pouch around the defect. Tuck my PTFE membrane in. Stabilizing sutures. Again, only using FDBA. This is what we look like right before membrane removal. This is what it looks like from the occlusal. And this is what it looks like right before we're about to place the implant. Again, look at the papilla. Look at the keratinized tissue. Yes, this patient does have a thick tissue biotype. But again, doing it any other way would have involved multiple surgeries to get this type of result prior to implant placement. This is what the CBCT looks like. This is what the ridge looks like before implant placement. And we're able to place a 4.1 diameter implant, primary stability. And here's what things look like restored. Again, don't love the crown, but look at the keratinized tissue. We actually created keratinized tissue. If you look at the pre-op versus the post-op, we actually created keratinized tissue. There's more keratinized tissue now than there was before because we reduced the inflammation. The defect was able to heal, and the patient is thrilled. 2 surgeries. That's it. So this is a young lady who presented to my office when she was 20 years old to extract a lateral incisor. Again, young lady in college. I need to make sure she has a wonderful aesthetic result. This is what the PA looked like. Resorbing number 7. Why is it resorbing? Well, because I saw her when she was 15. When she was 15, she was in a car accident, and I saw her at Children's Hospital. The lateral incisor was avulsed. They repositioned it. They splinted the tooth, and they sent it to me to have a soft tissue graft performed to give her, root coverage. And so that one day, we all knew one day you're going to get an implant, but we need some soft tissue there before we do that. So what do? I place a soft tissue graft. She goes off and heals, and she comes back to see me 5 years later, and it's time for the implant. But again, I've seen her since she was 15. She's a young lady. I need to make sure that we get a really nice aesthetic result. So what do? What I just showed you already. Atraumatic extraction. Pouch the buccal. Again, P. Charles periosteal elevator. Tucking a PTFE membrane in, just using FTBA. Pouch it tuck it in on the palate, and off we go. That's it. Stabilizing suture. Cross stitch. That's it. This is what we look like prior to implant placement. And this is what our ridge looks like. And again, look at the clinical photo of the ridge. This is good bone. This is high quality bone. This isn't particulate. This is bone where you're not, drilling at a low speed because you're afraid that, particulate's going to go everywhere. You can put any type of implant you want in here. We got such great primary stability that we provisionalized it immediately. And then she had school. She went off. She came back to get the final restoration. But she couldn't come to my office for the final restoration. So I said, here's the photo that I took of you before. Mirror that with your iPhone. So she took a photo of the final restoration with her iPhone, and she did a pretty good job with it. But look at the result that we were able to achieve. Look at the keratinized tissue. Look at the papilla. We've seen, no loss and a beautiful aesthetic result. And she was thrilled. So let's go bigger. Bigger defects. This walked into my office, and I told this man, when someone walks into my office with a defect like this, and this is what the PA looked like. When someone walks into my office with a defect like this, the first thing I say to them, and the first thing I recommend you saying to all of your patients, is my goal is not to give you an implant. My goal is to give you an aesthetic result, and that might include a bridge. And you have to be honest with your patients with that. An implant, if you're going to condemn them aesthetically for the rest of their life just to get an implant in there, it wasn't worth it. We've all seen those cases. Every single one of us has seen those cases come in where, yes, someone was able to place an implant in a central incisor site, but it looks like crap. And now what do? So my patients that come in with defects like this, I tell them my goal is to give you back your smile. My goal is not for an implant. We might use an implant, but you also might get a bridge. But my goal is to do no harm. So some people might say, well, what about soft tissue grafting this? Well, I can't soft tissue graft this first because of the infection. On the right is a similar case where, yes, I did soft tissue graft because there was no infection present. Here we used a big connective tissue graft. And yes, it heals, and now we can do it. But in this case, we had to take the tooth out immediately. As a periodontist, I got very excited about taking this tooth out because you saw that there's calculus at the apex of this root. I was really excited. So, of course, as a periodontist, I took my Cavitron, I was like, let me clean that off first. Let me see what things look like. So I had a sparkly root apex here for no real reason. Maybe it did help take the tooth out without the calculus buggering up the tissue. But took the tooth out atraumatically. I was able to preserve that epithelial bridge that I did then sever. But that was just style points. Papilla completely intact. So what am I doing? Same thing that we talked before. I'm not afraid of leaving these membranes exposed. Pouched around the defect, tucked my membrane around the defect on the buccal, onto the palate. Here I grafted, and because this was the first major defect I used, I made a mistake. Here I grafted with a combination of xenograft and FDBA, and I'll show you why that matters down the road. So here I'm using sutures to kind of stabilize everything together, and we let it heal. 2 weeks, 3 weeks, 4 weeks. I just kept letting everything go until about 8 weeks. At 8 weeks, I took out the membrane. But again, you see how the soft tissue responds. At 8 weeks, I took out the membrane. And what do we see in the residual socket? We see more particulate this time. And that the reason is because I used a xenograft. And as we know, xenografts stick around for a really, really long time. This is a CBCT that I took at 2 months just because I didn't believe that there was still something there. And there was. But for the next 6 months, the patient would come back in every few weeks and I would pull little pieces of xenograft out of the soft tissue. And that's where I went wrong. I should not have used a xenograft because it stayed too long. It worked its way through the tissue. But we continued to let it heal. And at 8 months, we re-entered to place the implant. And lo and behold, we have a ridge and we have bone, and not particulate looking bone. We have true bone. We have vital bone. Well, I didn't do histology, but it bled. We're able to place an implant, have it restored. The restorative dentist got a little creative by adding some composite on the crown on number 8 because the patient didn't want another crown as well. But again, look at the keratinized tissue. Look at the interproximal tissue. This was 2 surgeries. This was extraction, socket reconstruction, and then implant placement. And that's it. Even bigger. So now we don't even have a fenestration. Now we have an actual dehiscence to the apex of the tooth. It's infected. So we know we have to take this tooth out. Trust me, I'd love to soft tissue graft this first, but we know we have to take this tooth out. And I'm going to go even further. This is a 2-pack-a-day smoker. So what did I talk to him about? I said, listen, you might not get an implant, but my goal is to not compromise you aesthetically. And I said, you smoke 2 packs a day. You have horrible oral hygiene. Obviously he didn't really care too much about how things looked, but I did. Someone's central incisors. That's my business card. It's got to look good. So what do? We've done it before. Took the tooth out atraumatically. Didn't touch the papilla. Pouched around the defect. Placed my bone graft. Placed my membrane. Tucked it around the defect. Tucked it on the palate. Sutures to stabilize. Let the membrane sit there. 8 weeks. Let it wait. Wait. 8 weeks. Look at the soft tissue response. Really very little inflammation. Membranes removed. And this is what our CBCT looked like at 3 months. And this is what our soft tissue looked like at 3 months. So now it's time to place our implant. Again, here I waited 8 months. Defects like this, I'm waiting 8 months. This is what our ridge looks like. Implant placement, excellent primary stability. Look at our papilla. Really able to keep the papilla almost exactly where they were, keeping the keratinized tissue. And here we are with a provisional. I still don't have the final photos for this gentleman. I think because he liked his provisional so much, he maybe never came back for the final from the general dentist. So, when we're making decisions as far as anterior tooth extraction, this is what goes through my mind. So we have a non-restorable tooth. Patient comes in. if there's no recession, if there's a buccal plate present. So I don't use these DPTFE membranes for everything. I use them for cases when there's no buccal plate. So if there is a buccal plate present, I'm either placing the implant immediately or I'm just using allograft and a collagen plug. If there's no buccal plate, that's where I'm going to my DPTFE membranes. I'm using the TXT200, the single, doing the exact same technique I showed you, and that's what I do for all of these cases. Now, if there is recession, if there's infection, well, we're gonna skip the whole soft tissue augmentation part of it, and we'll go to using the DPTFE membrane and the allograft. If there's no infection present, I will try to do a soft tissue graft first, just because, I do think, as far as I think actually I've gone more and more away from this, but back deep in my head as a perio resident, is what my perio faculty would want me to do. I probably still would soft tissue graft at first, but I've started going away from that. Even in sites of recession, I'll just lay the DPTFE membrane down like I showed you before. So once the soft tissue graft heals, 6 weeks later, that's when I'll go in and I'll use I'll take the tooth out and use the TXT200 single with an allograft. Waiting times, healing times, so no recession. If there's a buccal plate, I'm going to place my implant immediately, or I'm going to put a allograft in a collagen plug. I wait 3 months, come back, put my implant in. Doesn't matter, maxilla or mandible. It's a 3-month waiting time. No buccal plate, I'm going to use the DPTFE membrane and the allograft like I've showed you. I wait about 4 months. When there's recession, for those cases, anytime I'm doing a larger defect, I'm waiting 6 to 8 months. The longer, the better, typically about 8 months. So what are the keys to success? I showed you how to reconstruct sockets of the anterior aesthetic zone. But at the end of the day, it comes to taking out teeth. If you're not good at taking out teeth, that's what you should be taking courses in, not bone grafting. Bone grafting should not make up for poor extraction technique. When you take out teeth, you need to do no damage to the interproximal papilla. You need to try to avoid damage to the buccal plate, and you really have to try to avoid flap access. It goes against a lot of what we were taught when we were in dental school. Hold of the buccal, lay a flap, take some bone away. But you have, section teeth, destroy the tooth that's about to come out. Don't destroy what we're leaving behind. Don't get primary closure for these cases. Primary closure when you're using a DPTFE membrane is not needed. It allows for more keratinized tissue, and it keeps that mucogingival junction where it needs to be. And then also your case selection. Give your patient realistic expectations. I'm never going to promise the world to my patient. I'm going to tell them everything that's going through my mind. When someone comes in with a huge defect, I'm going to say, this is a big defect. My goal is not to make you look ugly. I'm going to try to be as conservative as possible. And I know I do implants, but you may get a bridge, and you have to be prepared for that. And I think having patients with realistic expectations is a true key to success. Luckily, again, using these techniques, that happens very infrequently. We're able to place the implant, but you have to let patients know everything that's going through your mind. So taking this all in, a case comes in tomorrow. Here's a real world case again. This is Kathy. Kathy is again, young female, high smile line, very concerned about aesthetics. Why is she very concerned about aesthetics? Because I've known Kathy for about 4 or 5 years, because she came to me back in the day looking like this. She had trauma as a teenager, had an implant placed at number 9, had endo done on number 8, and was very, very unhappy with the gingival margin contours, with recession that she had on number 10. So, and Kathy was nitpicky. She pulled out the mirror and the Explorer and said, I want this and this and this and this. And, me and her restorative dentist sweated a little bit, but we were able to enhance her smile through a combination of crown lengthening, soft tissue augmentation, and she was thrilled. But then Kathy comes back to my office about 4 years later, and she looked like this. She came back. She still looked great, but she came with a copy of a CBCT in her hand. And poor number 8 is in trouble. We have no buccal plate. We have a periapical lesion. And she says, Sean, I love what you did to my gums. We're going to put an implant here, and it's got to look the exact same. And I said, Kathy, you're going to drive me crazy again, aren't you? And she said, yes, I am. So, okay, here we go. I told her all the expectations. I said, you might end up with some sort of cantilevered bridge. You might have, I can't promise you the world, but we're going to take things step by step. So what do I do? Here, I'm using a periotome. I'm going for a very atraumatic extraction. I'm trying not to mess up the soft tissue that I was able to create before. So it's like sad for me. We take out the tooth atraumatically, keep the papilla intact. God forbid I flap this next to that implant that's already lost some bone. You talk about goodbye papilla, it's goodbye papilla. So atraumatic extraction. This is what it looks like from the occlusal. Papilla completely intact. Very little trauma to the soft tissue. P. Charles elevator, pouching around the defect on the buccal. There's no buccal plate. Pouching all the way to the apex. Here I'm using the TXT 200 single. Very easy to use. Trim it, just like a soft tissue graft, tucking it into the pouch that I created around the defect on the buccal. Placing FDBA, tucking it on the palate. This is how she leaves before I put the sutures in. And this is, I saw her actually this morning. We just added these to the presentation. But this is what she looks like 3 weeks later. This is when I took out the sutures and I took out the membrane. Again, papilla still intact. Mucogingival junction hasn't changed. We're going to have plenty of keratinized tissue. And if you look, the gingival margin's actually a little bit more coronal, but that's just from swelling. But, at least it's not apical. But this is how she left today. She's going to come back in 2.5 months for a CBCT to see how she's doing. And we're going to place a guided implant for her so I don't have to do any sort of flap elevation for her implant placement. And we're working with a prosthodontist that'll most likely do an immediate provisional for her, which will be great. So thanks for the presentation. I see I have a timer. You guys don't see a timer. I have a timer. 20 seconds to spare. So I'd like to thank Blake and Osteogenics for inviting me to speak. They paid me to speak tonight, but by no means do I have any stock in their company. I just use their product and I take a lot of pictures of them. So, I use other people's stuff too. But Blake, I appreciate it. To the left, that's photos from their Osteogenics Bone Graft Symposium. I was very lucky to speak at it. Truly, truly, truly a great meeting if you're interested in guided bone regeneration. If you have any questions, take your phone out. That's my email. Email me anytime. I don't care. I have a Instagram. That's cool now these days. The residents at Ohio State do my Instagram for me, or they try to, because I don't have time for it. But yeah, Blake, I'll open up to questions. Hopefully everyone's
absolutely
still.
All right. Thanks, Dr. Rotenberg. That was fantastic. Tons of really good information there. But yeah, we want to get to some Q&A here. We've got a couple of questions that have already come in, some really good questions. But just a reminder, if anybody's still out there listening, we'd love to have some more questions come in. That button there is at the top right of your screen. Please feel free to go ahead and submit those questions to us now. Dr. Rotenberg, one question that's come in is that occasionally clinicians will object to using non-resorbable membranes for ridge preservation because they have to see the patient back for a second procedure to remove the membrane.
Yeah.
Will you just discuss why that is or isn't an issue for you in your practice?
Patients are typically coming back for 2-week post-ops for most procedures. So all I do for this is schedule, instead of a 2-week post-op, I schedule them back for a 3-week post-op. So it really doesn't add clinic time. It's just, we just delay the typical 2-week post-op an extra week. So, and to remove the membrane takes all of 30 seconds. It really doesn't add to chair time or extra appointments.
Okay, so you're just using it as an opportunity to see the patient again, make sure everything's going the way it's supposed to, and just kind of
Yeah, I'd
bump
say
the
most.
time frame back
Yeah,
there just a little.
I'd say most clinicians after socket reconstruction do a post-op. A couple weeks later, I'd say the majority probably do. It's just ingrained in their normal post-op schedule.
Okay, and then another question here. On average, how long does it take you to perform a socket reconstruction in the aesthetic zone?
For a simple case, even for the cases I showed, max 12, 15 minutes. It's not a long, to pouch the defect, to tuck the member. These are not long procedures. Yeah.
All right, makes sense. There's one more question here. I think most people have seen the answer to this now in your question and your presentation now, but I'll go ahead and ask it anyway. Why don't you use a collagen membrane in that similar technique that you were showing earlier with the TXT membrane?
Collagen membranes aren't bad. I like collagen membranes for certain things. I just, with the collagen membrane, when left exposed, it does break down. So the tendency is, to try to get primary closure with it, which again can change the mucogingival junction. The bone quality that in my hands that I get when using a PTFE membrane, it's better bone quality. I think most people, I don't know if people out there have experienced it, but when you use a PTFE membrane and it works well, it's really good quality bone. It's dense bone. And I find the quality of bones better just in my hands compared to a collagen membrane.
Perfect. Well, that kind of wraps up our session here. I want to thank you again for your time. Thanks everybody for attending. Dr. Rotenberg, man, what a fantastic presentation. What a great way to spend our Wednesday evening here. So thank you so much.
Oh yeah. Thanks for having me. I appreciate it.
All right. And remember everybody, we'll send out a feedback survey here in a little while. But again, yeah, thanks just for your time. Have a great evening. Goodbye.
All right. Bye everyone.